So this is a interesting topic. I'm a bariatric surgeon, foregut surgeon, and usually we don't use this for bariatric surgery, but things are changing. Let me see here, nothing to disclose. We already saw this. What is important that the ICG is almost atoxic, and you can use it anytime you want once you have the equipment. That's how we use it. Usually we dilute the amp with 10 cc's of saline, and we inject several times. These are the current applications, and you can see from the previous papers all the future applications. So for bariatrics, I've seen some reports, and I will show you what is published. There's some early reports a few years ago for gastric bypass, but if you're a bariatric surgeon, you will say, I don't need ICG, I can recognize if something doesn't look good. But I think having the opportunity or the possibility to use ICG can improve certain situations, mostly for redo operations, for patients who have many operations in the upper GI tract. I think that's very important. The previous presenter about the gastric pull-up, we currently use that for the esophagectomies. We found some very interesting findings about areas that they look good with the naked eye, but when you do fluorescence, they don't look great. So what I think is very important that all the new equipment is coming with the option of fluorescence. The robotic surgery systems, they all have this built-in, which is very important. Different laparoscopic devices, we are trialing the Striker right now, which is a great device. And it's very easy to use. You just press a button. You don't have to bring any extra equipment to the room. And if you go with the cost, because people say, well, it's costly. Once you have the equipment, each use is $70. And it's usually available in the hospitals. Our neurosurgeons and ophthalmologists use it all the time. So it's nothing that you have to go and look for especially. What we do is we give between 2 to 4 cc's each time. Now, we know that if you have to do multiple reads, you have to increase the amount of ICG that you use. So if you use 2 cc's at the beginning, you have to double that if you want to do a second or third look. So we know that sleeve leaks are a problem, but from the last review is about less than 1%. Leaks are improving, are not as common as at the beginning of the sleeve experience. So in order to draw conclusions about ICG, you have to have a lot of patients in both groups when the sleeve complications for the leaks are very small. But I think that the role